My name is Dr. Matthew Nainen, and I'm a thoracic surgeon, and I essentially do cancer surgeries in the chest. That is my specialty. And most of the cancers that come to us are lung cancers, esophageal cancers, cancers from various other organ systems that go to the lungs. The lung is a common place for cancers from all around the body to go to. And also very unusual cancers in the chest. Those are the kind of cancers that we treat. If you look at the commonest causes, it would be tobacco. You have people without tobacco exposure with genetic abnormalities, and people with those genetic traits being exposed to environmental factors like radiation from nuclear plants or radon or something like that. So this forms the main basis. So you can see that there's a strong environmental component to this. But man is part of our environment. We have to interact with our environment. And environmental risks are always going to be with us, whether they be infectious or non-infectious. And it is just the question as to gradually, as we change, the threats change too. I would say that the biggest red flag for lung cancer would be a persistent cough. Now, often when it reaches the stage of a persistent cough, lung cancer is reasonably advanced. So in its very early stages, lung cancer does not have many symptoms. The second is if you're spitting up blood, hemoptysis. This is also a late symptom, but some patients can have an earlier. So those two, I would say, are the majority of symptoms that you see. If you have a persistent cough and spitting up blood, then the risks go up even more. Or if you have a persistent cough and weight loss and lethargy, tiredness all the time, loss of appetite, this is another major red flag. I would say every year for a population of 330 million, we have about 200,000 new lung cancers every year in this country. The incidence is higher in the southern states as opposed to the northeast and the west of the country. The southern states like Kentucky, Tennessee, Alabama, Mississippi have very high rates of lung cancer. And this could be related to the tobacco use because these are traditional tobacco cultivating areas. The death rate from lung cancer is about 160,000 a year. So as many new patients we find, another similar amount is actually dying from lung cancer every year. So lung cancer causes more death than the next 5 common cancers put together. So it is the major reason for cancer deaths. If you look at how many patients are presenting in early stage as opposed to the late stage, I would say even today only about 15 to 20% are presenting in the early stages. And 85% are presenting in locally advanced or advanced stages. Now, if you look at how many patients are being operated on every year in the country, which is a good indicator of how many patients are actually getting treatment in the early stages. We don't know the exact numbers, but it could be anywhere in the region of between 25 to 40,000 people every year. And that is, we need to increase those numbers. So what we need to do then is to say, okay, how can we find these patients in a stage in which we can cure them? Now, this is a big challenge because if you look at thoracic cancers, the reason the thoracic cancers cause so much of death from cancer is that a lot of the patients present to us late. So if you divide them into 4 stages and say the first stage is the earliest stage and the 4th stage is the last stage, about 85% of the patients who have lung cancers, for example, present to us in stages 3 and 4. meaning that's the first time they come to a doctor, and or should I say that's the first time that they are diagnosed with the problem. So this is a major challenge for us, that we have to find patients in the earlier stage. Now, even if we find patients in the earlier stage, still a small proportion of those patients will relapse, will have recurrent cancer over the course of the next 5 years. So the next challenge is, the first challenge is to find them early, and the next challenge is to find those patients who come to us early, to find which one of them is actually going to have a worse outcome than the others, and add treatments on, so that in a way that you can make sure that they don't the cancer doesn't come back. So these are the two major challenges from a public health standpoint that we are facing as far as treatment of these cancers are concerned. So if we take the first one and say, how can we find these patients early? Well, we can do simple things. That is, that patients who have a history of tobacco use or who have strong environmental exposure, they get proper checkups from their PCPs, insist on some sort of chest imaging. A chest X-ray is reasonable, but it's not going to show you everything, and have a high index of suspicion. Especially in primary care, if you see an abnormality on the chest X-ray, on the lung fields, you need to take that very seriously, because in an adult that often means a major problem. So, and that needs to lead to more investigations, etc. What we find is that a lot of patients are, seen with chest X-ray abnormalities, but they are either ignored or they are said, well, we'll take care of it later, etc., etc. And thus patients, get delayed. The second is that people who have symptoms like cough or weight loss, etc., and who have a history of tobacco use, they often tend to go to their physician late. And this is the other problem. So even though symptoms start, they don't go to their physician. And the third problem is that the lung and chest structures, many of them do not have any pain fibers. So people cannot feel pain when the cancer starts, and so they don't recognize it in the early stages. I would say that the vast majority of the patients get to a late stage because they do not have symptoms. So the question is, in these patients who are asymptomatic, who do not have symptoms, how can we find them early? And for years, we did not really have any data that said that we could use any modality to try and find these patients early, till recently. So a few months ago, there was a big trial whose final results were published in the New England Journal of Medicine. And this looked at screening of patients for lung cancer, just like you would screen patients for breast cancer using mammograms, or for prostate cancer, etc. And what they found was that if they used a certain CT scan, which is essentially a low radiation dose CT scan, meaning it has just a little bit more radiation than a standard chest X-ray. It is quick and easy to do. It does not need contrast or something injected into your veins for us to see. So essentially it's like an X-ray, but you're lying on a CT scanner gurney. And it takes a few seconds to do, essentially. And this is called a spiral low-dose CT scan. However, things are not simple. One is that Medicare and other payers have still not decided to pay for getting your scan. We think it may take about $200 to $300 to get a scan. And that is not being done, number one. The second issue is that lung nodules and masses in the lung, especially for example, in the Tennessee Valley or the Ohio Valley, are very common because of the presence of a fungus called histoplasmosis. So we need to be careful in how we are diagnosing these patients. What kind of algorithm do they go to once we find an abnormality? What we really do not want to do is to do a lot of unnecessary biopsies and a lot of unnecessary smaller surgical biopsies. We don't want to do that. So there is a challenge in trying to find the appropriate patients to do this. But it can be done very well if you have the appropriate expertise to get that done. So the next question is, should we get everybody in the country who is at high risk to undergo CT screening? This is a question that is still open. But what I can say is that a lot of institutions are already getting into this, are offering this to patients. In some places, patients are actually paying for them out of pocket to get it done. And I think in the areas in which there is a high incidence of lung cancer, geographically, high tobacco use areas, especially like the south and southeast of this country, and also in patients who are at high risk, I think that CT screening is a worthwhile effort, because the other side of the coin, like I said, is that the vast majority of these patients are presenting late, and if we need to reduce the death rate, we need to find them early. So I would say that today lung screening can be advised if the program is set up appropriately, it has the appropriate expertise to read those scans, interpret it appropriately, and not do unnecessary biopsies. If we can do that, then we have a good thing going here, and we can reduce the death rate from lung cancer. Now, the next question is, if we find lung cancer early, what is it that we can do to cure these patients? And surgery does offer them a great option at that time. I would strongly encourage people with very early stage lung cancer to consider minimally invasive surgery. The reason is that I'm not saying that an open operation is in any way inferior right now. That's not what I'm claiming. But what I'm saying is that if you can do it appropriately, you can do the same thing in a minimally invasive fashion, then maybe that is the way that most people will want to consider. That has been a big change over the years. And then the next problem is that we find patients very early. How are we able to treat them in addition to surgery, that we may be able to reduce the chances of this coming back? I would say that if you find them early enough, about 70% of the patients live 5 years or longer after this. And in lung cancer, once you live 5 years or longer after your first cancer, the chances of it coming back reduce dramatically, unlike breast cancer and other cancers. So we are able to assure at least a 70% 5-year survival, and we can assume that the majority of those patients are cured of that first cancer that they've had. Those 30%, there's a lot of research going on. Why are they, even if they are early, why is the cancer coming back? And we have a lot of trials that are looking at either giving them chemotherapy or giving them immunotherapy, which is vaccines against lung cancer, using the newer anti-cancer agents that are called targeted agents or targeted therapy. So using chemotherapy, targeted therapy, immunotherapy, which is vaccines, etc. These are all areas of fertile research, and there are some major trials that are either going on or have already closed, and we are waiting for the results of these. So there's a lot of work going on in that area. The team approach is the absolute critical element here. That is where we are going to get the best outcome for the patients. So if I were to put it simply, is that we need to find these things early. If we find them early, we need to treat them appropriately. We need to consider minimally invasive therapies, and we need to have a team approach to seeing which is the best treatment for these patients. So I would say a great way to get a lot of information is to go to the Mini-Pearl Cancer Foundation website, minipearl.org, and that will give anybody searching for answers how these cancers present, what are the usual symptoms, what do you need to do if you think you have the cancer, what are the local resources that are available, whether it be physicians, nursing, even palliative care. So all that together is at that one website. So that will be very useful.